Welcome to the CARE Challenges and Solutions for a Sustainable Future International Conference. Thank you for joining us for the fourth and final session of the theme, Technology and Care, Opportunities and Obstacles in Place-Based Care Contexts. My name is Matthew Lariviere. I'm a lecturer in social policy at the University of Bristol, and with Andreas Hoff, one of the co-conveners of this theme. I'll be chairing this session on the topic of evaluating technologies to support care systems and outcomes, challenges, and opportunities for evaluating assistive and digital technology situated within national care systems. This session consists of 3 papers from scholars in the UK, Spain, and Germany, followed by a discussion of key areas of convergence and divergence across the papers. I'd like to introduce to you the first speaker of the day, Nicole Steils, a research fellow at the King's College London. Nicole's talk is entitled Telecare in England, How Well Is It Working and Could It Work Better? Over to you, Nicole.
Many thanks, Matthew. Yes, as Matthew said, my name is Nicole Steils, and I work at the Policy Research Unit in Health and Social Care Workforce at King's College London. And today I present on findings of a study into telecare and assistive technology provision to older people in England. And this was called the Utopia study. At this point, I would very much like to acknowledge the leading researcher on this study, Dr. John Woolham, and also my other team members. Thank you. First slide, please. Some background information on assistive technology and telecare, and also how it is provided in England. So when we talk about, for this study, talk about assistive technology and telecare, we mainly mean electronic equipment that is situated around the house or very in close proximity to the house of an older person. And we're talking about things like emergency button, pull strings, monitoring sensors, such as movement sensors, but also gas detectors to prevent fires. And these devices will be monitored outside of the home. For instance, by an older person's unpaid care or their family members, but also by some monitoring services. Sometimes these are provided by local authorities. Sometimes older people can pay for them themselves, but we have also come across places where there were no monitoring services, so it would refer back to some carer of an older person or obviously the family of the older person. I should maybe point out at this stage for international delegates especially that social care in England is provided by local councils rather than the National Health Service, or short the NHS. You might have heard about that. So interest and use of telecare is not a new thing. It has been around since the 1960s, where telecare was used in sheltered housing. The interest in sort of policymakers' views has started at the end of the 1990s, where policymakers in England provided guidance and also funding to explore and increase the ways that telecare and assistive technology was provided to care users, with a view and an aim to maybe avoid moves into long-term care, into nursing homes, or to avoid unplanned hospital admissions. In 2008, the whole system demonstrator project was commissioned, which was a very large, if not the world's largest project into the use of assistive technologies. And this found that, so it looked into the outcomes and also into cost effectiveness of use of telecare, but also telehealth, which is a different field that we didn't look into in our study. And the outcomes or the findings were sort of a little bit vague around whether it actually improved outcomes for older people. There were very good outcomes, but there were also findings where telecare would not improve the care for an older person, and also cost effectiveness. There weren't really real savings found in this study. So sort of in this context, we started the Utopia study in 2016, and I would like to talk about that next. Next slide, please. So as I said, we have done the Utopia study, which we started in 2016. The study was funded by the National Institute for Health Research School for Social Care Research, and our objectives were to explore how local authorities use telecare as part of a social care provision, sort of called package for older people. We used a mixed method approach and issued a survey to all 152 local authorities And we asked them to forward this to their senior managers leading on telecare provision and services, and we achieved a response rate of 75%. In the next stage, we undertook 25 in-depth interviews with telecare leads, so again, senior managers leading on telecare provision. And we had a third stage, which was our case study stage, and we went back to 4 local authorities, and here we interviewed telecare assessors, commissioners, staff working monitoring centres, people responding to alerts generated by telecares, but also we interviewed older people and their carers. Next slide, please. Sorry. I will now present on some findings from the survey and our interviews. A very important step of the provision, if you talk about it in stages, is obviously the assessment. And we found that telecare was usually only provided by local authorities if an assessment of an older person and in the home of an older person was carried out. But we also found some exceptions, and I will come back to that. There were 2 very distinctive ways of carrying out these home assessments. One was an integrated approach, where the older person was assessed for their general care needs, and the telecare assessment, or the assessment for the use of telecare, was part of this assessment. These assessments were usually carried out by social workers or care managers, and it was argued that this would allow a better matching of social care needs and telecare directly. It was also felt that less departments were involved in the assessment, which would speed up the installation process. The other way was a separated assessment. So the assessment for social care needs was carried out first, and then an assessment for how telecare could maybe be used to provide services and to match those needs were carried out by a specialist. And here the argument was that a specialist would probably have better up-to-date telecare knowledge, might also know about ingenious ways of using telecare to meet the needs of an older person. We also found that the assessment was often used to maybe already install some basic telecare equivalent. So again, in a way, this was also speeding up the process of providing telecare assessment. I said that we found that there were exceptions, and this was the case for some devices. So some local authorities, not all, but some local authorities provided especially emergency buttons or pull strings and the associated monitoring equipment over the phone. So an older person or a carer could ring and ask for this equipment to be provided, and it was going to be installed without a home assessment. Sometimes telecare equipment was also installed to allow a discharge from hospital of an older person. And we found that some local authorities provided equipment to self-funders, so for people who would pay for their own social care. And again, this could be provided just by a phone call. A bit worryingly was also that many reviews of telecare use or telecare service provision was done over the phone rather than a follow-up assessment or a new assessment just to check whether the telecare actually worked for a person. Next slide, please. So what was considered in this assessment? And as you can see on this slide, most local authorities really would assess the older person's mobility, their daily routines, and would also consider mental abilities and impairments. However, a third indicated that they did not assess a person's grip strength or dexterity, which would obviously affect the person's ability to use emergency buttons or pull strings. And we also found that a fourth said that they would not necessarily assess a person's insight into their abilities or disabilities. And about half did not assess a person's ability to problem solve. And again, we think that the lack of abilities could severely impact on their ability to use telecare successfully. Next slide, please. We looked at training and how it was provided to people to staff who would carry out telecare assessments and also then provide installation services or maintenance services. And we found that over 80% of local authorities were providing training to their staff. But we also found that this was usually on-the-job training, or it was of very short duration. And it was very often provided by the main telecare manufacturers in England, which made us wonder what the content of the training was. Was this mainly focusing on how devices worked, or was this also used to maybe introduce just new equipment? Next slide, please. We were interested in how unpaid carers, and that is relatives, but also neighbors and friends, were involved in the provision of telecare and assistive technologies for older people. And we found that unpaid carers played a very considerable role in this provision. They were involved at the assessment stage. They often attended an assessment. They would provide information about the older person. They would also provide information how they were involved in the care of the person at this stage. They were also involved in the maintenance of equipment. So not so much in installing it in the older person's home, but if it came to changing batteries or looking, just making sure that it worked after a power cut, if there were any malfunctions. Many local authorities relied on unpaid carers to make contact if there was something going wrong. So it can be argued that a lot of equipment would obviously self-raise if there were issues, but especially in places where there were no monitoring services, the local authority would rely on an older person's carer to make contact and say there was something wrong with the equipment, for then a maintenance service to come out and check this out. And this was obviously, this was the case in about 20% of local authorities that we surveyed. And unpaid carers played a considerable role if it comes to responding to telecare alerts, whether that's alerts generated by the older person themselves by maybe clicking the emergency button, or whether a sensor would go off. So obviously in the places where there were no monitoring services, it would go directly to the carer for them to respond. But it was also the case in local authorities that had monitoring services. About half of them would ask unpaid carers to be the first responder. In the other half, they would send a mobile response service and also paid for these services. We sort of were interested in looking into the future of the role of unpaid carers, and we found that many local authorities had plans to increase the involvement of unpaid carers. However, only a small minority of local authorities offered an assessment of carers in their own right. And I should probably point out at this stage that carers in England have the right to have an assessment of their own needs if they provide unpaid services. Next slide, please. So in summary, and what could work better? We think that more rigorous assessment conducted in the home of an older person are necessary. And we think that an assessment should be seen more as a process. So follow-up assessments, better reviews, again, as I said, carried out in the home of an older person are needed. And this will also avoid the deinstallation and decommissioning of telecare equipment of an older person, especially shortly after initial installation. We think that telecare staff need more, better and more independent training so that it focuses more on the complexity of telecare use rather than maybe just the use of how devices work and how they are installed. And we also think that unpaid carers need to be better acknowledged in the role that they play. So the unpaid carers need better support. They might need some training if their role is to increase. But most importantly, they have the right to a carer assessment and they should be offered one, and not just if they ask for it. Next slide, please. So these are our publications for the study. This is the study report and some peer-reviewed papers. And maybe over to the last slide, please. I would very much like to acknowledge and say thank you to all the participants in our study. And very importantly, just say that the findings and arguments presented today are those of the research team and not of the funding bodies. And well, thank you very much for your attention and your interest today. And thank you to the organizers of the conference for making this possible. Thank you.
Great. Thank you, Nicole. That was a great presentation, very concise and clear representation of Utopia and its key findings there. Thank you. Now we're going to move on to our second paper for the day. This is from Blanca Deusdad, who's Associate Professor at the University of Rovira, Virgili in Tarragona, Spain. Nice to meet you, Blanca. Your paper today is entitled Socatel Project, a multi-stakeholders co-creation platform for better access to long-term care services. Over to you.
Thank you, Matthew. Good morning, everybody. As I'm associate professor at the University of Tarragona, which is one of the Catalan public universities in Spain, and I'm coordinator of this project Socatel, which I'm going to present some findings and a bit of overview of it. So next slide, please. What is Socatel? Next slide. Very briefly, we co-create a co-creation platform for digital co-creation. And apart from this work, as interdisciplinary work, we also had as outcomes digital long-term care services to face, and had certain impact, to face the emergent needs in an agile way. We could say that also we have adapted the situation of COVID at the end of the project, and we could try to readdress these needs with the participation of all stakeholders, as we will see. So next slide, please. Socatel, apart from this co-creation platform that has been made through research, through focus group, qualitative research, and also face-to-face co-creation workshop with all stakeholders, has as a tool a knowledge base. It's important so as to in each of those long-term care services available, because one of the shortcomings was the lack of information about the services available, and also to remodulate them and not to reinvent or to make new ones, reinventing the wheel, knowing previously prior to what there is already available. We have also, apart from digitalized care services, we had also carried out hackathons in 5 locations in Europe, and this has helped to digitalize these services prior to be co-created in the platform. And we can say we hope to have certain impact in terms of social media, and also in terms of policy and in terms of market. So next slide, please. Societal. So the team, next slide, please. Well, it is, as I said, an interdisciplinary team. It is composed by 13 partners from different backgrounds, universities, like, for instance, Trinity College, but also practitioners like HAC in Tampere University and the municipality of Tampere. There is also companies, software developers, for instance, one leading in accessibility like Funka, CIRIC, an SME, or Everis, a multinational. So there is a huge diversity of partners. Next slide. This has been a challenge, but also a strength of our project that has had to have discussions and also made a glossary about the common terminology to use. We also have an advisory board to assess us from different experts in Europe in different fields, for instance, Tepe Kreger, Oliata Yalon, Begonia Roman in ethics, or Britt Oslund, among others. Next slide. Oliat Greenfeld. The Socatel methodology. We have also created a new methodology, and what we had implemented is the approach of the quadruple helix. That means that all stakeholders were involved, from society, family carers, as we have seen in the previous presentation, professionals, healthcare professionals, but also the private sectors, service providers, researchers, and policymakers. And we have done this in 4 contexts, in 4 case studies, in 4 locations in Europe that we call pilot sites. in following the classical typology of Spink Anderson on welfare states. We had the Nordic country, Finland, with Tampere University and Tampere Municipality. We had also the case of Ireland, more familiaristic Anglo-Saxon model. Then we had from Southern Europe the case of Spain, in the case of the City Council of Villanova. And from Central Europe and Eastern Europe, we have the case of Hungary and Budapest and a third sector organization, SEGET. So next slide, please. We carried out qualitative research in these 4 locations in Europe. We had about 251 participants in the 4 locations, Ireland, Finland, Spain, and Hungary. And from there, we had results about how was digitalized and how was working the long-term care system in each of these countries prior to the co-creation workshops and digitalized. So next slide. Some of the results that we had were presented in these 2 papers, one on the human technology from the University of Jyväskylä and the other one in the technology forecasting. And what I'm going to say, was similar in the 4 case studies, the results. What I'm going more to present is the case study of Spain that I was more leading. And in this case, we found that there was in Europe, in the 4 locations, different degrees of digitalization. I mean, there is a heterogeneity in systems, but not only at the terms of Europe that there is not interoperability, but also at the national level or at the regional level. So there is not, especially in the social service and health service system. No, in Spain, for instance, social services are in charge of all health and care issues. No, all care issues. And then what we also found, and is quite worrying, is the lack of information about the care systems and the care planification of resources that stakeholders do not know, end users or their family cares, they don't know. So there is not information about these services available in ETA level or enough spread into the population. Another aspect we found that was not according to the Tallinn Declaration was the administrative complexity. The principle of once only was not followed, but also that was complex to understand what it needs to be done and to fill in. So for all the adults, this is really a challenge, and even for their family cares. Another aspect that was highlighted was the lack of coordination among professionals and how integrated care is still not enough or sufficiently developed. And this has been even more highlighted and dramatic in the case of COVID-19 crisis, how integrated care did not function well, and this was having consequences, particularly in nursing home, of death, all, as we know, in all Europe. And also coordination sometimes needs to be by family use presentation. This is all the burden on care that have family cares. And then also the transparency of the process when you apply for services. It is difficult to know this. And then what we found in positive way that the technology was used or was seen with certain enthusiasm, but limitations, but professionals, they found that could be helpful for reduce the bureaucratic burden and this administrative complexity, but it could not in any way substitute, under any conditions, substitute face-to-face meeting and connection with end users. And also they will use it in certain creativity, WhatsApps and contacts with clients, for instance, for family cares, not family cares, care workers, sorry. So next slide, please. I'm not going to go deep on this, but we also to co-create this platform with knowing better the user experience, having interface meetings, co-creation meetings, internal tests. We also carried out digital co-creation pilots when the platform was ready to test, these hackathons to digitalize the service co-create. And then in the last phase, we had digital co-creation to address COVID-19 emergent needs, no? How to find a way to tackle this. So next slide. The platform has 5 phases. No? The first in the process of co-creation. The first phase step would be co-ideation, co-definition. The second, co-design, co-development, and co-validation. And there is a facilitator that helps to all this process to go from one step to another to all stakeholders participating in it. The first phase, co-ideation, it's a phase where people can express their needs and also ideas and can be both. And then the facilitator, when there are interesting ideas and which has been both, can pass to a step 2 to have a co-definition, to see which are their barriers and their strengths. And once the co-definition phase is accepted, can pass to the third step, where there is a business model to define how this service is going to be implemented or designed, and who is going to participate, sector, organizations, public sector, etc. And then when this service is in this step, there is the possibility that some entrepreneurs, service providers, municipalities see that it is interesting to be developed. And then there is a competition in step 4, they pass to step 4, where there is the prototyping of the service, and also stakeholders can provide feedback to the people who decide to develop or digitalize this service. Then this service is supposedly developed and pass to step 5 to see the co-validation, to see the last feedback and co-validate the final service. Next step.
Why do we need change? The population of the world is aging fast. The number of Europeans aged over 65 is expected to double in the next 50 years, putting a serious strain on resources. This, coupled with the ongoing threat of communicable diseases, highlights the importance of the digital transformation of health and care. Why co-creation? There is a need to transform the way we design and develop long-term care services. This transformation needs to be inclusive, accessible, and allow all stakeholders to contribute through a bottom-up approach. Co-creation provides a tool to do this, helping to address real user needs and to co-design and co-implement effective services. Why digital co-creation? Co-creation can happen face-to-face. However, this traditional method can prove to be time-consuming and costly. Digital co-creation has multiple advantages. It is a low-cost way of facilitating collaboration among people located in different places without the need to travel. It also makes it possible for interaction to be more frequent, involving a diverse range of profiles. Finally, it means that participants can co-create whenever and wherever in a way that is more spontaneous and democratic. What is Socatel? Socatel is a platform through which digital co-creation can be carried out, involving service providers, professionals, end users and their families, and researchers. Users are able to browse the platform to look for existing services in their area. If no existing services are available, Socatel enables the co-creation of long-term care services in 5 easy steps. 1. Co-ideation of real user needs or ideas. 2. Co-definition of these ideas. 3. Co-design of services amongst different stakeholders. 4. Co-development, connecting service providers and entrepreneurs with stakeholders' ideas and needs. 5. Co-validation, testing the services with stakeholders to provide feedback and improvements. For example, a pickup service for Anne who would like to participate in more social activities but who has a physical disability restricting her movement. What is the added value of Socatel? The Socatel platform helps to contribute to the transformation and innovation of long-term care services, leading to a more sustainable, balanced and cohesive society. The Socotel platform provides a more cost-efficient way of developing long-term care services, improves the satisfaction of older people and their carers by meeting their real needs, facilitates large-scale discussions for co-creating long-term care services, provides a knowledge base, including a list of services available in real time, builds a virtual community where participants can offer each other support. For more information, if you are interested in implementing the Socotel platform, please contact us for more information through one of the following channels: www.socotel.eu.
From the digital co-creation, we had next slide. We had some digital service. For instance, this where we had. I put one pre-COVID and another post-COVID or in COVID phase. It was context. The first one was one on what we identified the isolation of all adults and lonely as we know Europe. And what we try to do is an app that facilitates mobility and integration in the social activities. The idea that was emerged from the hackathon we carried in Barcelona with our 30 participants, and this idea was the winning one. This team group, what they proposed and what they developed at the end was an app that the aim was to have the possibility of a GPS. We can see which activities were in the area, in the neighborhood, in the village, whatever, and also to connect with a voluntary service to pick up these people and to bring them there, and also a mobility service. It's a pickup service with taxis or with some transport, no, and a way to be possible to be more inclusive. And then the other app was a remodelation of an existing app in Villanova, where there were services online, home delivery of services in all the shopping that in the municipality that can be online, identifies so other services, etc., that could be food, different. That next slide. And well, at the end, I just would like to acknowledge the people of my team. We did this, and also the cell partner participate, and also disclaimer that this is part of our work, but responsibility of the European Commission. So thank you very much. Thank you for listening.
Thank you, Blanca. That was a great presentation. Really enjoyed hearing about the methodology of Socotel and how you're doing this co-creation work with the wide range of stakeholders involved. So thank you for that presentation. Right, and our third and final paper today is from Maxie Lutze, who is a group leader at the Institute for Innovation Technology in Berlin, Germany. Maxie's paper today is entitled Assessing the Benefits of Assistive Technologies in Place-Based Care, the NAAM Model as Theoretical Framework in Germany. Maxie, it's great to meet you. Over to you, please.
Thank you very much, Matthew, for the introduction. Yes, as you said, my role in the Institute for Innovation and Technology is a group lead. I'm leading the group of demographic and social digital change there. And I'm going to present a study that was focusing on assessing the benefits of assistive technology for people in need of care. And we developed a framework called NAAM, which is the German abbreviation. And if we would put it into English, it would probably be something like benefit model for the application of assistive technology for people in need of care. So next slide, please. Let me come to the background first. As I said, we will focus, or we did focus in the study on people in need of care. And this is due to their vulnerable situation, really, with regards to the increasing relevance of digital care and the number of research and innovation projects that are taking place in this field. In comparison, assistive technologies are adopted only very slowly. There is a lack of systematic investigation on the effects of assistive technologies, and this again leads to limited evidence, and in turn this leads to a challenge for reimbursement, other challenges too, but we focused on reimbursement, and of course this is a challenge. And since the presentation was planned quite a while ago, and also the study took place in 2018, I would like to refer to some developments that happened in Germany in the meantime. In November 19, there was a Digital Care Act release, which is the app prescription law and is related to the fast track evaluation procedure from 2020. And also announced was another act, it's called the Digital Care and Care Modernization Act for 2022. And as we did brief research before this conference, we could see that there is an increasing research on frameworks for evaluation with regards to technology and healthcare systems. And since 2019, we found more than 8 new models, and it shows that there is a high interest in this field. Next slide, please. We conducted the study for the Research Department for Long-Term Care Insurance of the National Association of Statutory Health Insurance Funds from August 18 to March 19. The objectives related to that were how to create the benefits, how to describe the benefits of assistive technologies for people in need of care. The second one, what do we know about the benefits of assistive technologies for people in need of care? And third, how can people in need of care be supported by assistive technologies? We did this in a multi-method approach. First, we started with literature analysis, identifying studies that actually assess the benefits of assistive technologies. We did an in-depth analysis of 145 studies, and also provided an overview of existing evaluation models. Then we did interdisciplinary expert workshops in order to reflect the current findings and also the model draft, and included 5 interdisciplinary case studies in order to validate and adapt the model. Next slide, please. And this is the NAAM framework. The model is to describe benefits in a structured way and to assess the underlying conditions for the use of assistive technology. With the model, we put a person in need of care in the center. We propose an approach that helps to generate relevant knowledge about the benefits of assistive technologies for people in need of care. The NAAM you can see here comprises 3 levels. The first one is called individual aspect, that refers to the person in need of care and includes their possible objectives and needs that can be supported by the use of assistive technologies, thereby maintaining or regaining the independence. We've got the second layer, it's the structure and process layer. This looks at the effects of assistive technologies in terms of processes and structures. This comprises objectives that can represent added value in terms of the design of long-term care processes and structures. And then we've got the third layer, it's called conditions of use. That includes aspects that can influence whether the potential benefits of an assistive technology can unfold or not unfold. And we defined certain questions for each layer. First one would be what benefits are generated for a person in need of care. Second one on the second layer is what effects does an assistive technology have on the immediate environment, so people and structure of people in need of care. And the third one is which factors help to unfold the benefits of the levels and which do not. Next slide, please. And here you see the complete model. There are always categories included. We've got 4 categories on the individual aspect layer. It's referring to independence here. Independence contains aspects that are mainly taken from the rather new assessment tool of the need a person in need of care might have. That includes mobility, cognitive and communicative abilities, and so on. Also, we have a category on participation, safety, and protection. And a really important one is also on autonomy and well-being, which should actually assess the subjective perspective of a person in need of care for instance, the subjective state of health. The second layer, structure and processes, includes three categories with different aspects. The first category offers and structures, for instance, includes how is assistive technology supporting the access to care. The second one would be how is assistive technology influencing processes and workflows. And the third one is very important, how is assistive technology affecting caring resources with regards, for instance, to burdens and relief. Then we've got the third layer that includes four categories with the person and living environment. Also information on care arrangement, which is really important if the implementation of technology is planned. So how is the situation? Are there family carers? Are there professional carers? Are they maybe cooperating? Who's actually helping with the use of technologies? And we have ethics and law. Very important also with regard to safety aspects, and the category technology design, which includes aspects such as usability, for instance. So now you know the NAAM. I'd like to go to the next slide, please. Now, what we also did, as I said, we analyzed 145 studies, and I want to give you some main insights we saw here. So the in-depth analysis shows that the research is really strongly interdisciplinary, which is good on the one hand because there are many disciplines needed, but it also causes a challenge with regard to lots of methodological approaches. We saw that many studies focus on usability and acceptance studies, and that there are only small sample sizes, which causes some trouble, especially when it comes to projects that focus on a certain target group, but they are not really researching on the subject group. So, for instance, if people wanted to assess the technology effects on people with severe dementia, they usually have trouble to include them into projects, so they cooperate with younger or elderly people in order to estimate the effects. We also observed short trial duration, probably no surprise. But what was more surprising is that the technology that was researched on in those projects was mainly in research. So 86% of the technology was not market ready, and compared to 12% that were market ready at that point. Next slide, please. And now I would like to go to the individual aspects. So we analyzed the different layers with regards or the studies concerning the NAAM model. And with regards to the individual aspects, we saw that mobility, cognitive and communicative skills, and social context are really in the focus of research here. The studies, and that was especially interesting for Germany, and take up important aspects related to the new concept of needs in long-term care that was defined in 2017. So it's not only focusing on physical aspects, but on social and mental aspects as well. The operationalization of the objectives is quite heterogeneous and somewhat incomplete, and this is a challenge when it comes to comparison, and especially true for categories I presented, such as participation and safety and protection. And what is the biggest challenge I think we discovered is that in many studies, the perspective of people in need of care wasn't involved as it should be when it comes to evaluating the benefits of technology. So the categories self-determination and well-being was rarely examined. Next slide, please. The second layer was structure and processes. This layer was also only addressed selectively, and the conditions for access to assistive technology and their integration into care processes were not very often reported here. Also, we saw that the role of elderly carers and professional carers, as well as the effect of assistive technologies on them, was not reported very often. It's not quite sure if people researched on them and didn't report it, but the studies didn't give a holistic picture on the effects of assistive technology as well. And what we also saw that many technologies are still tested not under real conditions, which of course is a challenge for the transfer of those technologies into care systems. Next slide, please. Let me come to the conditions of use. Also, we saw here that they are reported, the conditions of use, but also they are not very transparent, and there are hardly any structured reports really that report how technology is implemented and what efforts are needed. I think this was mentioned before in the first presentation, and this leads to a lack of information on the transfer of those technologies. Also, socioeconomic conditions, financing aspects are seldom reflected, so are liability and safety issues. Those are quite critical points, but what was also very positive to see is that there is an extensive knowledge about the design requirements and the interaction between users and technologies, which of course should be used in following studies. Next slide, please. Let me come to the last slide, conclusions and open questions. When we have a look at the NAAM model, what we experience in our research is that it can really help to foster an outcome orientation and not only a technology oriented evaluation process. And we also make the experience in the case studies that the research teams really had a structure tool that helped structuring the discussion and reflection for the design of technologies. What we don't know so far if it really helps to evaluate, because it's rather new, so there haven't been many applications of this model. What we can say from the analysis of the study, that there is a necessity for systematic analysis of the benefits for people in need of care. It doesn't make sense to have lots of studies to focus on only one aspect, or to only focus on acceptance, for instance. It's really important to do an outcome-oriented evaluation with regards to care outcomes. And therefore, it's also important to have a higher quality by reporting standards, by following them actually. And what we see from those studies, that is also very important in future to analyze the embedding of assistive technology into care processes and how they're actually influencing social structures. They do influence social structures, and sometimes social structures are newly designed, so it's important for evaluation too. And of course, long-term studies are relevant, but it's not only long-term studies. They really need to be linked to implementation studies, so that we get more information about the impacting factors when it comes to the implementation of those technologies. And I also brought two questions with me that derive from the study and are important to discuss in future, I guess. How to establish a future structure for more efficient evaluation. And actually, we also need to figure out what is the suitability and the relevance of those models all coming up, including the NAAM model. And I think this is a task we all have. Thank you very much. Next slide, please. I finished my presentation here. Those are the publications we included. Next slide, please. And I would also like to thank people who supported this research through time and really lots of effort. And you can also see my contact details here. Thank you very much for listening, and I'm happy to receive questions now.
Great. Thank you, Maxie. Great presentation. Touching upon actually a lot of the points I've been researching too, about looking at new frameworks for evaluation and design, linking them up with implementation and design, right? So it's kind of two different communities of practice there. I'm hoping we get a chance to discuss those in the discussion later on. But thank you for that presentation in the first instance. Now we're going to switching over to the discussion portion of this session. Before I introduce the discussant, I just want to say that we're going to have an opportunity for the discussant to pose questions to all three of the speakers. Then each speaker will in turn have a chance to respond to those discussions before opening to a wider discussion where all five of us can pose questions to each other, picking up some of the kind of key areas of similarities and differences across the presentations. Now, without further ado, I'm delighted to introduce to you Dr. Kate Hamblin, Senior Research Fellow at the University of Sheffield. Welcome, Kate. I'm looking forward to hearing some points you've identified across these 3 presentations.
Thank you very much, and thank you to all the presenters. There were some really fascinating presentations there. I'll start by talking about Nicole Steils' presentation. I thought it was a really interesting area of research that's often neglected. We don't hear a lot about the assessors and the assessment processes. But where we have had research on this in the past, it has highlighted the importance of these actors in care systems in co-producing telecare. You know, they bring in other actors like unpaid carers. They're really key and integral, and as I say, under-researched. And where in previous work that I've done, I have observed assessments and installations and the training that these people have. I agree. There's very little interaction with the user. There's very little checking that they can actually use that device, that whole grip strength thing. There's also misinformation about how the device works, and I've seen the training that is very much marketing exercises on the part of manufacturers of these devices. So really important area, I think, to highlight their role in telecare systems. And I think the presentation also highlighted issues around the huge diversity in local authority practice related to telecare, because in the UK we have certain statutory requirements for local authorities, but there aren't any related to telecare or technology in care services. So as a result, we do have very diverse systems at the local level in terms of how equipment is commissioned, how services around that equipment is commissioned, and the potential then that digital, and we are switching over from analog to digital in the next few years, that could potentially widen some of those gaps. And I think I'd like to pick on some of the issues around on assessments and what issues were considered. I thought it was very interesting that some of the categories of areas that were covered in assessments touched on areas of well-being, but didn't specifically use the term well-being. There were some categories there you could probably relate to relational, subjective well-being, but it didn't seem to be an explicit aim, which I think is interesting in the UK or the English context, because well-being is there in the Care Act. That is a statutory responsibility of local authorities. But I didn't get the sense that commissioners necessarily saw telecare as part of that well-being agenda. So what is telecare therefore doing for local authorities? Is it delivering something else? Is it delivering cost savings? Is it delivering ageing in place? Perhaps too well if people are bounded by these technologies to their home? Is it to support unpaid care workers? I wanted to maybe unpick that as to the aims of telecare really within these systems. I also wanted to ask you perhaps to talk a little bit more about unpaid carers. I've read your paper in Ageing Society, which uses Twigg and Atkins framework, and I think that's a really interesting area, and I think it brings us back to your question, that's your title, which is, telecare in England, how well is it working and could it work better? And I think the question around unpaid carers is okay, how well is it working for whom? How do we reconcile the needs of the various stakeholders engaged in telecare systems to decide how well is it working, and is it working well for everybody? If it's helping people to live well at home for longer, but it is placing an additional burden on unpaid carers, is that problematic? So I think that's an area we could perhaps unpick a bit around, if commissioners are very satisfied with how well this is working, but no one else is, how do we persuade commissioners that perhaps they need to reconsider how they are commissioning technology and care services? So that would be my reflections on Nicole's presentation. And moving on to Blanca's, again, another really interesting presentation that really highlighted the importance of co-production and that users are not peripheral, which has a nice link to Nicole's presentation, where users' well-being and their capabilities seem to be neglected and peripheral to assessments, but also the perspectives of other stakeholders like carers. So this work that Blanca presented brings in those neglected areas. I just had some things I wanted to pick up on around when you talk about the quadruple helix and professionals in this context. Do you include care roles that perhaps technology creates? So we have, when we traditionally think of care roles in care systems, we think about care workers, social workers, other professionals like that. But increasingly, technology does create new roles, new caring roles that are perhaps different in that they don't involve being located in the same place as the person receiving care, but they do have a caring aspect. So aside from assessors and responders, you have people at response centres, responding at a distance, deciding how care should be organised around a person. Are these people included also in the co-production model? Because I think there are important questions around the creation of roles within care systems that technology necessitates. What about those roles, the job quality, the questions there I think are really important. It's something that was raised in the UK context anyway during the COVID pandemic, because there had to be some quite fast lobbying to make sure these people were included as key workers alongside care workers, because they were sort of forgotten as part of the important caring networks that make all this technology and care function. I wanted to also pick up on the really common findings you found across different national contexts, which I thought was really interesting, because they're very different care systems, and there are different ways that technology has been integrated into the care system, and there are very different countries have very different places in terms of the journey to digital. So I wanted to ask you whether there are any things you think the UK could learn from other countries that are further along the digital journey, because in the UK we haven't yet switched off our analogue services. We still have telecare using telephone lines, but increasingly those are becoming less stable and sustainable. So what can we learn, really? And I finally wanted to find out a little bit more about the role of evaluation, because that seems to be the overarching red thread that runs through all these presentations. Can you tell me a bit more about the co-validation processes that you've used, and how you make sure that all stakeholders' perspectives are balanced? Because what might work for one group within care systems in terms of technology may create additional burdens on other aspects of those care networks. And it's just about how do you ensure all voices are heard in your co-validation, and how you create a sort of sustainable care, which is the title of the programme that I work on. And it's about trying to create that sort of balance, really. And moving on to Maxie, again, a really, really fascinating presentation, really brought to the fore important factors that mediate how technology works or acknowledge, so things like context and the impact that equally technology has on environments. So the idea that technology is created within context, and but also has an impact on those contexts. But I wanted to pick up on the diversity of assistive technology, and how your framework takes into account the different technologies and the different outcomes that they may produce in different contexts, and how you also capture unintended effects. So things like the debate around telecare as to whether it has almost enabled people to age in place too well, because a lot of it is place specific and doesn't function outside the home, therefore sort of tying people to their homes rather than allowing them to age actively. And in terms of your conclusion around systemic analysis, and it brought up to me ideas of hierarchies of evidence here in the UK. So the randomised control trial is almost seen as the gold standard, and the whole system demonstrated was the attempt to produce randomised control trial evidence related to telecare and telehealth. But as Nicole said, the evidence it did generate around telecare wasn't particularly persuasive, not much cost saving, and I think the phrase used was that it was found to be enhancing but not transformative of people's lives. But does that reflect the reality, really, of what telecare can do for people, or does it more reflect the fact that methodology isn't perhaps best serves to capturing the impact of a complex intervention like assistive technology? Because it is hard to embed technology in systems while removing all other variables that may affect outcomes, because that's not really how it works in the real world. And related to this, I think I wanted to talk about the relationship between evidence and practice. So it's often sort of said there isn't very systematic evidence on the outcomes of telecare, and that's why there's issues around adoption but what others, I think I'd like to reference the Utopia study, and one of the other findings from the project that, it actually had very limited impact on commissioning decisions. So although it didn't find cost savings and it didn't find that it was particularly transformative, it hasn't changed commissioners' patterns of commissioning of telecare. So how do we then mobilise the evidence we produce to change policy and practice? So I do have some overarching questions that aside from those presentation specific ones. So my first one is around sort of thinking about assessing outcomes and evaluating technology in care systems, which is the sort of overarching thread that runs through all the presentations. And my question is really, how do we capture complexity and context, but also produce findings that are persuasive and generalisable? So I mean by complexity, I mean the way that technologies are shaped, but also shape contexts within which they're situated. Also technology, we use this term a lot, and actually there's a huge range of technology within that is being used in social care, and increasingly we're seeing new technologies brought to the fore. Particularly in the UK, we're seeing a lot of local authorities experimenting with mainstream devices. How do we cover a lot with these terms cover a lot of ground, but how do we develop frameworks, methodologies to be able to capture the various different types and create persuasive evidence? And how do we capture the impact of these devices or systems on all aspects of care systems and networks? Who does it work for? Who does it not work for? I think those are important questions. What inequalities does it create? Who are disproportionately exposed to benefits? Who are disproportionately exposed to risks? I think those are important things that we should talk about. And can we ever create an evaluation framework that can work in very different care and technology systems? Can we ever recommend an approach to technology and care that would work in these different contexts? And even if we do create a perfect framework for deploying technology use in care, how do we then mobilise that evidence for change? How do we persuade policymakers, practitioners, users? And do we want to even go that far in care systems like the UK, where well-being is the aim, and it's a very subjective and personal concept? Do we ever want to be that prescriptive? But if we're not prescriptive and we don't have some sort of baseline, are we at risk of leaving certain people behind in terms of the benefits that technology may offer? So those are my comments and my overarching questions.
Thank you, Kate. Those are some really incisive comments there. Look forward to hearing the responses from each of the three speakers. So without further ado, I will invite Nicole, Blanca, and Maxie back to the stage with us. And we will go in order of presentations to hear responses. So it's Nicole, you are first. If you could respond to any questions that Kate has posed to you.
Sure. Well, thank you very much for your very thoughtful comments on this presentation. I mean, I was obviously only able to give a very snapshot of our findings, and there was quite a bit more coming out of that study, which is actually also a while ago. So, when I was listening to your comments, it's sort of, a lot of findings that I wasn't so much aware of anymore came to the fore again. And just picking up on what you said in your last comment about sort of prescriptive telecare, and that I didn't actually even talk about. That was one of the bigger findings from this study, that local authorities would basically have pre-packaged telecare packages, and would sort of provide them and say, this will solve your problems. But I think what you were looking for in terms of my presentation was how local authorities would answer social care needs in terms of, socializing, well-being, these aspects. We would definitely argue that the way that telecare was provided when we run the service in 2016-17 was very much focusing on physical health needs or care needs, was considering mental abilities, definitely, but it was not asking for well-being. We wondered whether they were asking about hobbies, about socializing, and how telecare could answer that. We also asked that in the interviews. We were wondering, whether local authorities would organize. I think Skype was very big at the time. Whether they would organize training sessions for older people, and we very, very rarely came across that. So not in the survey and also not in interviews. Some local authorities seem to be ahead, if I might say so, because I think that would be very important. And telecare or technologies can support socializing. I think we've all found out over the last year that older people could be, or older people's care could be improved, enhanced with using technologies, but we just couldn't find very many examples of where that was the case or where telecare was used. In terms of carers, I think, does it work for them? I think I put on the slide and also in that paper, are they taken for granted? And we felt that was very often the case. Specifically, we felt so they attend the assessment of the older person, but it felt like there were, I call that in that framework in the paper, a resource for information, and then also a resource for providing care services. But their needs were, as I said, not assessed. We could only find 2 local authorities where we have definite that they would always offer a carer assessment. I mean, it's an offer. Not every carer might pick it up, but we had no indication that was the case all over the country, and rather the opposite. And I think there's other research being done that's very, very general the case. So it's not just around telecare provision. It's also around other ways of answering social care needs. I think we shall probably not forget that the research was done in times of austerity, where local authorities had to discover or had to live with great spending cuts around social care budgets, meaning that thresholds for social care provision were upped and upped and up. And I guess at that point it really sort of went into more paying attention to physical needs rather than social needs. So these needs, I don't want to say that they are ignored, but there wasn't enough. It felt like there wasn't enough money for this to do. But again, you could find intuitive ways, not very, not costly ways of answering these needs. Was there another question? Sorry, Kate. There were too many questions.
Thank you. Yeah, no, and I think you just touched upon COVID-19 and potentially that changing things slightly, because we've seen the accelerated use of technologies. We don't yet know whether for good or for bad in care, to facilitate social contact and things like that. We don't yet know what the impact of that really is systematically, and we don't know yet whether those things will be retained when we go back to normal. But yeah, no, thank you. Very interesting.
Great. Thank you, Nicole. Can move on to Blanca, and having you an opportunity to respond to Kate's queries as well.
Thank you, Matthew. Thank you very much, Kate, for the questions. Very helpful, and your insights also. Much appreciated. Thank you very much. Well, just a comment on what you said now about the COVID-19 context, how it has changed. I mean, I think in our project, what we see, just to say that is maybe a bit of background. It's an H2020 project that is an innovation action. So we have to work on sustainability of and certain products from the project itself. No? So what we see is that we were a little bit ahead of our time, that digitalization, that we were talking about co-creation, digital co-creation, and everybody was difficult when we did the focus groups to try to have ideas about this, but no one a little bit know exactly what we were trying to do. Even ourselves, we were co-creating at the same time. But now, in the context of COVID, this is digitalization have become more important, and I think it's here to last. No, but of course, as social scientists, we need to be critic and to give somehow not all technology, because it's disruptive or it is whatever, we have to accept. So we need to see and to assess that it's not easy how this technology is going to have an effect on all the adults, on care, quality, well-being, etc. So I think these are very pertinent questions, and I think the assessment, as has been highlighted here, it's important. So maybe I answer your second question. I try to answer what to learn from this from the UK. I think it's a very ambitious question. I don't know if I can answer. No, I would like to. But maybe I can underline a few things, that technology is important, but everybody was staking that face-to-face contact is still important, or we cannot avoid in care, or aspects like time, giving more time on care. These elements were also important. Also, what we found that could be helpful is more community engagement in care. No, I mean the community, all these networkings that was easy to build, not easy to build, but was helpful to build through social service networkings. I mean, involvement of professionals was a way to facilitate, to generate this networking and these groups of people involving in care and participating in the project. And how this could be important also to be stable for the future. Don't just stop, but to have this building this networking of community engagement in care, because also we know that it's a crisis of care, no, Nancy said, and I think it's important to face this. So these would be some of the aspects, and also integrated care. I think it is still, at least what we see, it is not still functioning well enough. And I think it's important to have this social and health integration, and for these aspects like this, as you was saying, Nicole, before, no, the importance of social life, on isolation, and to ameliorate all these aspects. So I would say this is some findings that might help, not on technology, but that goes together, that needs to accompany technology. No? Regarding your first questions of the quadruple helix approach, we include all the people involved at that time in care. For instance, managers of care workers, service suppliers, organizations of partnership of private and public. I mean, also policymakers in terms of people that were working at technicians for instance, in the city hall of the municipality of Barcelona, no, city council. So I mean, we had a broad extension of professionals. I don't know if you refer to this or some emerging ones from COVID. This we didn't identify. I mean, it was the same professionals that were there. So we have from care workers to social workers to also geriatricians, primary care doctors. I mean, we do all spectrum. In this sense, I'm quite sure that it was covered, at least in each area, or the area I was carrying out the research. And then the third question that I think it's very important also is the co-validation. Just to say, because it was also emerging with Maxie and Nicole presentations about, especially Maxie, about the involvement of all the adults in digital. No, I imagine one of the questions would be from you, how we are going to involve all the adults with the digital divide in digitalization. First, we have to say that we don't have to have an ageism stereotype. No, there are people in the late 70s or 80s that they know how to use or they like internet. But of course, it's not the majority. But what we did, and also to add people with physical disabilities, intellectual disabilities, no, with needs in this regard, not people with dementia, we don't put, but someone with intellectual disability and aging. What we did is we have the figure of a body to help to participate in the co-creation process. So this was a way to solve. And so we try to involve everybody. And in the co-validation, what refers this area is once as I said, it needs to be active in the market. No, the project has this aim. So once the digital service is already developed and designed, can be uploaded to the platform, and people, stakeholders, can provide feedback on it. Of course, you sometimes need to launch the call for people. You need to contact the networking, as I said before. But then the people can give feedback on the service and say if they like, if it's useful, what they prefer or not. Previously, it is a co-creation process. So, for instance, about age-friendly aspects can include or interfaces, etc. No, how we would like, but it is the co-validation, and the idea is to also launch the call to the quadruple helix, all the stakeholders. No, this is the way we try that all voices would be heard. Of course, can be more people participating than others. I mean, we work out careful with the numbers of the different stakeholders participating, but of course you cannot assure when you open a call on co-creation, no? And it seems that professionals sometimes are the ones who have more voice, maybe. But for instance, in the hackathon, in the jury of the hackathon, we had all the people participating in the jury. So we were in all the project very careful about this idea of the quadruple helix, and particularly involving all the adults. But of course it is, and we found these ways. And also some ethical aspects that I'm not going to go further on this, but were there, requirements, etc. I don't know if it's more than...
Thank you. Mm-hmm.
Great, thank you, Blanca. That's a great response to the query raised by Kate. And finally, Maxie, I'll give you the opportunity to respond to Kate's questions as well.
Yes, thank you very much. Thank you very much, Kate, for your questions too. I try to answer them as good as possible. Maybe you have to intervene again. I think one of your questions was like what happens if we use all those technologies, and if we really create the evidence at home, and if technology then ties people to their home. I think I'm not really sure actually if we observe this result so far. So I wouldn't start with the fear that we actually tie people with technology to their homes. I think still it is quite important to figure out what is the need or the objective of the person in need of care. And I think really here lies the potential of a model like this to not look at the commissioners first, not look at the system at first, but really put people into focus who should profit really or benefit from those technologies. And if staying at home is an aim, it could be an okay outcome, I think. So it's if it's the individual perspective. And we also included, as you saw, categories like participation, which includes the social context, which could be from being inside, but could be also like being outside and meeting other people, be involved in events, in shopping, whatever is really meaningful to the person. And what I'm really convinced of during all the times within this studies and the research in general, that it takes time, and technology is like part of care. Really, it's not something that can do something in care, but it's part of care. And that for me means that the assessment procedure, and I think Nicole referred to it as well, is very important to see what a person wants, and this is maybe even more important what the infrastructure can provide, and then also consider the infrastructure in order to, or the care arrangement, really, it's not only the technical infrastructure, in order to make technology work in a situation. And you also raised the question why is there only vague evidence? I think this might be, of course, I don't know in detail because I don't know about Nicole's research in detail, but I really think it's related to, do people in the closer environment of people in need of care understand the technology? Do they accept it? Do they understand the complexity of the system? So where do they get help if something doesn't work, for instance? And if they really think it's a way to support people in need of care. So the perspective of professionals as well as family carers is very important, and I think it's underestimated in many projects because we, at least in Germany, and I'm quite sure it's the same in UK and Spain, the burden for people who are caregivers, they sometimes don't even consider themselves as caregivers, and they don't even know how to express their needs when it comes to caring for their family members. So I think again, if it's this framework or any other framework, I really think you have to recognize the complexity of the system. And when it then comes to your other question, how to mobilize evidence, or actually how to create evidence, I think it's a cooperation approach you need here, really. We've got a small but interesting approach in Germany. I'm counseling too, and there are different organizations from different care contexts: acute care, elderly care, hospital care, home care. They're working together, and they try to figure out what are really the differences of implementing technology in different contexts, and then they exchange on their findings in a big network. And I think, or big network, in a network at least, and I think those approaches should grow. So I'm not sure about your countries, but in Germany at least, this kind of network is not very well established so far. And I think this is needed in order to mobilize evidence on those technologies. Also, I think that wasn't your question, but I thought what really connects all of the presentations is the well-being aspect. And I really think we should have a look at well-being, because, like, especially if it comes to the end of life, it's lots about well-being. It's about well-being of family members. It's about well-being about people in need of care. So this category in our model, or this approach, is really needed for evaluation in general. And now my last remark, if it comes to RCT studies you also refer to, the question I ask myself is, do we have RCTs with regards to all the other measures we implemented earlier? So I don't think we have this baseline really. And as was mentioned before, technology came and it's somehow influencing everybody's life, if it's care or not care. And so I think we should more focus on what are positive results and negative results, and also unintended results. You mentioned it, Kate, that's very important, but probably we will still go with lots of qualitative research, but here it is very important to exchange on the results and slowly build up the possibility for actually having RCTs. I'm not sure if RCT stands at the very beginning of providing evidence for the use of those technologies. Okay, I finished my remarks here. Thank you.
Thank you.
Great. Thank you, Maxie. Kate, would you like to respond to those responses?
Oh, thank you. That was really helpful. And I think, yeah, the well-being thing is a really interesting concept. And I think because in the UK, the history of telecare and technology in care is, as Nicole said, from the 1960s, sheltered accommodation. And it was about this shift away from residential care services to allowing people to age. in the community, either in sheltered accommodation or their own homes. So it was quite risk averse. It was about managing risk and making sure that people who weren't receiving round the clock care and residential care were still able to summon help. And it's not really shifted in the mindset necessarily of commissioners away from being quite risk averse. And it is, it's often part of hospital discharge packs. It's not really aligned with those well-being, the well-being agenda as yet. And it's how we help it get there, perhaps, as researchers. And as I said, one of the unintended consequences of the pandemic is perhaps that has raised awareness of where technology is being used to facilitate more well-being focused outcomes around interaction and connections, and maybe that will take the agenda forward in ways that research perhaps hasn't yet. That's really my reflections on really well-being and technology, and how it hasn't really in the UK got there as yet, but it may be on its way.
But it's a double-sword aspect, because technology can also go against well-being. It can be for, but against. And to measure this, because
and whose well-being as well,
to reduce the care burden, of course, to facilitate administrative or bureaucratic burden, to integrated care, this aspect that also was a little bit here, I think is or to relieve, to provide information, to help in this, but to monitorize health, and this I think needs to be discussed and assessed, and it is an aspect to debate. Very interesting. And I think also one aspect that was in all presentations was this care burden of family carers. I was also happily impressed by Nicole when you used the term family carers, because we from the south we had this, as our familiaristic systems, the figure of family carers, and we just found first in the Anglo-Saxon concepts, the informal carers, but we said, well, it's not exactly informal, it's more. So I'm happy that now it's already the word, also the concept used, because it is a reality. And it is true, as Maxie said, that sometimes we even are not aware that we are doing all the care, the manager of care in the family, and all this lack of integrated care and coordination among professionals. Family is the one who sometimes have to supply all these. So it is. But I think it needs a debate about all this use of technology for well-being. I think here there is research, and also has been pointed out the importance of assessment of this, how it's used, not to know. But we need to have a voice in all this, because it's here, it's to last, I think.
And something we observed in a previous project we did, called the Active Project, was the way that technology actually could shift care relationships. What we would call informal, perhaps, because they're not family, but like neighbours who perhaps wouldn't consider themselves to be the carer of somebody, but now they're being put down as a first responder by the telecare service. So that formalises that relationship between those two people. Whereas perhaps they would have maybe took their bins in, or done small tasks for them, but now they're actually got a position of responsibility. It's a very formal thing now. They are caring, they're part of that caring network, and that's because of telecare, that's because of these systems, how it draws certain people in, and as you say, how technology can potentially push other aspects out, so removing the face-to-face. So it does have huge implications, I think, for the way these networks are formed and function.
Kate, what I'm wondering about, for instance,
Sorry.
You just were referring to the influence of technology on informal carers too. I'm wondering if this relationship formalizes, as you call it, if it really motivates more people to involve in informal caring, or if it keeps them away, because technology, of course, has also the potential to register what did you do, and you've got those time platforms, right, where you can actually give your time, but you have to do it digitally and tell, okay, you will use this time to spend with someone else or to support someone else. And I think this formalizes informal care a lot too, and I'm not sure if this really helps for the with regards to the relationship. I think this is a huge question to me. Really.
Yeah, and I find drawing on the philosophy of science is really helpful, right? So you're not just designing a new care technology, right? You're potentially designing a new intervention for how we perceive, understand our kind of social imaginary of what care is, right? So again, it might be formalizing new relationships, as Kate identified as well, or some other aspect of the kind of material, relational, and affective kind of dimensions of caring, right? We're not just intervening, we are shaping that imaginary.
Yes, so the expansion of what care is beyond body work, as Julia Twigg would call it, is now not involving touch necessarily, but it is still care practice mediated by technologies.
Right, did anyone else have any questions for each other now? Now we can open up to wider discussion now. If it helps to have a bit of structure, does anyone have any questions for Nicole?
I have a question. Just asked me most was that you said that telecare was complex, was difficult to use. I mean, from the idea I have of telecare had been a lot in the case. So I follow her, and about telecare also in the south of Spain was very much pretty important, and also in all Spain. But I wouldn't say it is complex. So maybe I missed something from here, but because to push the button was like something very simple, and that was not complex, and that people feel very safe. It is enlarged here with fire alarm, but well, needs to be evolved something more complex. No, hopefully there are studies on this too. But I couldn't say from the experience here of the older people is to touch the bottom. And also what has been important during the COVID, by the way, was the voice messages in terms that people could talk with them and could follow up, and sometimes they help to primary care through telecare to check about all the adults how they were. And also is a way some people that they feel alone or feel frightened or whatever, they push the button and they talk a little bit with the tele assistant that is in the other side. No, so here it's not feel as complex at all. But I don't know if I misunderstood something, because sorry, sometimes language, or what you refer from. Okay, so this that was a bit stuck in. Right.
No, I don't want to say that it is complex for the older person to use it, but it is in the end. So I'm taking up on your example of pressing the emergency button. So what happens next? The alert goes out, let's say, to a monitoring center. So you have already someone else involved who then needs to ring the first responder. The first responder might not answer. It goes to the second responder. The second responder doesn't answer. The older person might be clicking the button again. Someone is trying to talk to that person. Maybe the person isn't able to respond vocally with the monitoring box, might be in distress. Maybe then a responder is found. Is that now the right person to go, or does it need an emergency service? Does it need to be an ambulance? So I think there are a lot of complex decisions made that actually happen after the button is pressed. We just said about formalizing the situation. Is it actually right for a neighbor who might be living beside that person for quite some time? signed up. Yes, okay, I'll be the first responder, you know, but is it the right person to answer that call? What happens next? Let's see, the person has only been in distress, an ambulance wasn't needed. You know, is the local authority responsible to do a wellness check? Is the local authority doing that? Or is it the neighbor who's going to do that? Are there other family members who needs to be informed? So that is what I meant in terms of complexity. Not so much just having that button. I think, yes, it gives a lot of you know, peace of mind, as it's called in English. You know, this idea of safety and having a level of security around you that you wouldn't have without an emergency button system. But I think that the technology behind it and the relationships and the people behind it, that is what is complex. I hope that answers your question, and in a way it was meant to be.
Thank you.
I think that's part of the issue with telecare. It looks like a very simple thing, and that ignores this complexity around it that enable it to function. You know, it's very simple technology and it doesn't generally fail, but the care system around it can fail. They send the wrong response, you know, or, you know, from the perspective of the user, it can go wrong in other ways than just I pressed the button, nothing, it didn't send the signal. I pressed the button, it sent the signal, but they sent my neighbour and I wanted my daughter, or they sent an ambulance and I was fine. You know, there were other things. That's where I think it becomes complex. And in the UK, as I said, there was this sort of, because it is just assumed to be this button and that's it, but actually it's the response centre, it's the people who actually physically go out and pick people up off the floor that weren't seen as key workers until it was sort of lobbied by the representative body of that organisation that they were key workers during the pandemic, and therefore, you know, their children could still attend school. They needed PPE equipment. They needed all these things that key workers get, because they're sort of forgotten otherwise, because they're not seen as part of the care, but they are really integral to making these things function. So it's a tricky one, I think, because it looks so simple, and it is like we want to think about technology as being really efficient, but actually its efficiencies are contingent on people who are sometimes forgotten.
Absolutely. Just one comment. In the context of COVID, I mean, people were more reluctant to push the button because they don't want to go to hospital. And here, for instance, when you push the button and there is any problem, the ambulance is sent so as to simplify this. But of course, cost efficient, or maybe, as you said, Nicole, you don't need the ambulance, no? But people were more reluctant to push the button because, you know, to go to hospitals was not the best solution at that time, no? At that moment, or in these moments.
Very interesting. Yeah.
Thank you both. Interesting.
Nicole, I've got a question for you too. You said, if I understood it right, that the commissioners maybe didn't have the time it wasn't paid for the assessment. Do you see any changes there?
Sorry, you have to repeat that question. Sorry, there was a feedback.
Okay. I understood it that way, that the assessment of how the impact of the technology is on people in need of care couldn't be conducted due to money issues because there wasn't enough time and money to do so. Do you see any changes there with regards to the role of the commissioners and this issue? Is there an improvement to assess the needs and the impact of technology better or more systematic?
Right. Yeah. So we don't really have an answer why reviews were often done over the phone. I would put that into the general context of how reviews are done in general. So reviews of social care packages and looking at other people's research would indicate that reviews are in general done over the phone. And would just affect all social care provision, not just if needs were answered by telecare. Whether this has improved, well, I have absolutely no indirect indication from Utopia, because Utopia stopped at that point, and we haven't had any chance to follow up on that. Maybe my colleagues from the UK can help me out here, but I wouldn't have an indication that it has really improved since over the last 2 or 3 years. I would actually assume that with COVID,
It's got worse.
It got worse, yeah. Even in 2019, I didn't really, or colleagues of mine, who were more involved in home assessments, have seen improvements on that aspect.
And there's the issue of the sort of individual micro level reassessment, and there's also the issue of how commissions assess the success of their service, how they monitor telecare services. I don't know whether you did touch on this, Nicole, but certainly something we've observed in the past, and maybe it's changed, but local authorities just wanted a very big picture monthly report from the company providing the service. How many times was the buttons pressed? How many ambulances were sent out? How many responders were sent out? Because then they could do the maths on it really and say, the emergency responders were sent out X number of times, and we know that an ambulance call out costs Y, so therefore we saved Z. So that's great. Those sorts of macro level pictures was what they were really interested in, and we sort of asked, when your social workers go out, do they pull the records of individual people to see how they're using telecare so they can talk about it when they see someone? I've seen that you've pressed your button quite a lot recently. Are you okay? Well, no, why would we do that? They weren't really sure why that would be a thing to do, and it wasn't something they even really could do directly. They'd have to then contact the company providing the service to do that, to pull that individual record of that person, because everything is so contracted out that they don't really have that direct relationship with the data that's produced. So the reassessment at the micro level are sort of just an annual thing, really. Even an annual is kind of generous, actually. It was probably less likely to be annual. And, not really. There wasn't really that follow up. How are you getting on a month after it's installed? That didn't really happen. You're sort of left to it. Really. And if you want to change anything about your telecare, it's up to you to sort of manage that. And a lot of the people we spoke to had no idea who to contact, because they were getting these devices installed when they're being discharged from hospital a lot of the time, or recently being bereaved, so they're on their own. When they were seeing, maybe for the first time, a huge influx of social workers, discharge teams, they were having new equipment put in their house by re-enablement, all different parts of local authority and health systems, and trying to disentangle how to get and contact with the various parts of the system to talk about the relevant bits of equipment was just, they couldn't work it out. It was just too much. To try and really instigate an assessment or to give feedback on the equipment was something just far too complicated, really.
Yeah, I would definitely echo that with findings. We asked whether local authorities were using information, were collecting information on outcomes from assessment, from reviews. And we were also sort of, why would you do that? And and exactly that. Yes, we were counting the number of how often alerts are generated, or false alarms are generated, and so this was a sort of natural follow-up question. So what do you do if someone is falsely pressing the alarm very often? Well, we decommission the alarm button because the person is apparently not using it correctly, and that's in a way a kind of risky answer, because there could be many answers why the person is pressing that button perceived too often, and there might be underlying needs that are not answered. They could be social, but they could also be physical.
Actually, as a comment, I would say this for me reflects
these
again.
Services have a lot. Sorry.
Go first. I think my line is lacking. Sorry, Maxie.
Blanca, please go.
I was just thinking that of. Don't you think that sometimes these services collect a lot of information? I mean, that they have, for instance, social workers who are in charge of this, or the manager, whatever, who is responsible. Getting a lot of information, but this information they don't know how to analyze And also it's difficult to get in from researchers, no, like here, to analyze, assess, like data, but it is not really used for an assessment or an improvement, or there is not systematic. There is not a systematic analysis or review or whatever about all these data, no.
Absolutely. Something we've seen in the UK is there is an emphasis on our data and how it can be used for prevention, and there are some local authorities that are investing in this and creating things where different data sets are aggregated and put and publicly available so that people can sort of play with the data. So these police data, local authority data, all put together for people to do, as you say, to try and make the most of it, really. But again, as with a lot of what happens at local authority level in the UK, it's hugely diverse. There are some that are doing these amazing things where they've got these data mills or lakes where it's all there for people to look at. But then some, I'm sure, is still paper and it's in a cupboard because they haven't got anyone to type up to put it into a computer to do anything with. So there is this. We've got this big diversity here.
And not to forget that there's an integration between health data and social care data, so data that the NHS might collect, the National Health Service collects, and that the local authorities collect.
Good point. Maxie, you had a question. Please go ahead.
It actually refers to the question I was raising in my presentation. What is a good structure for generating evidence? And I think it needs a collaborative approach and not only focusing on is it a false alarm or is it not, but really thinking about what do we need to know from the situation of a person in need of care. So how can we collect data at home? How can a person in need of care or the family members or other informal carers support those collection of information so that we actually know what happens at home? I think this is still somehow a black box, and we don't want to use cameras to find that out. So we need to find out a way to communicate it. And I think data can help us to do that. But in order to have useful data structures, really, I think there are many different levels we really need to figure out what we really want to know and why do we want to know it. I think what you just mentioned, we document it because we have to, and no one is really looking into the information. That's also a waste of time from my point of view.
I think I have a personal fear there, whereas that we're going to rely on data, which may be abstracted, deterritorialized from people's actual lives, rather than just talking to them about what their goals are, what they wish. Right? We don't know if the data will be used appropriately, how robust it is, the ethical questions about why we're collecting that data. Right? So why is there so much emphasis on collecting big data? Well, we don't know the quality of it. We don't know how it's going to be used. We don't know how it's going to be protected, who will access it, who will ultimately benefit it, rather than just trying to have time to have conversations with individuals about what do you see as your goals, right? What challenges are you having instead? So I think, is technology actually the only way to reframe these challenges and future sustainability issues or look at well-being instead of actually just looking at kind of more human-centered and mediated interactions instead?
Yeah,
sorry, Blanca, I know you're about to
agree. I absolutely agree to your point of view. I think communication would be the start, but then I would like to ask back, like, who should do this kind of communication? Who should be involved? Because I think there are some really good examples that show that peer communication, especially when it comes to older people, is very important. So maybe the assessment of this communication is not necessarily be done by professionals, but can be also done by people who actually speak the same language. But people, of course, need to be informed what to find out, really. So I think who is communicating and who should interact, that's also a question for me.
I would
I will
echo
follow on that
that.
right away. Go ahead.
And
Go ahead, Nicole,
one
please.
thing that
I would echo that, but also we basically asked the telecare leads, what is your approach? What is your aim with this assessment? And I don't. Well, we came across some people who basically said, well, we would love to have really person-centered assessments, but we don't have the budgets to actually provide the care services, whether that's technology or otherwise, to actually really answer them. So I think this brings back the idea of, not the idea, the issue of austerity of the last few years. These were often people who said, it was different. We are aware there are possibilities, there are options, but they're just not, they're not open to us. So I think there's an issue with sometimes with reality in terms of what is money-wise be able to do, and what could be overcome maybe in more, as I said before, in June ways. But even for that you need money, because you sort of need the headspace and the time, maybe to have another assessment or another conversation with an older person or any person, to answer these social care needs. And I don't think that time is there at the moment, in terms of official assessment carried out by local authorities, social workers, or care managers.
So something that we've seen in the Sustainable Care Programme is a recent shift in some local authorities to explore digital mainstream technologies as ways to deliver services, but also well-being, because the argument being that, the analog systems are going to be switched off. A lot of the telecare is going to need to be decommissioned and replaced. And what we replace it by is a question, because the digital versions of it are more expensive. So that's a cost. Mm-hmm. So even to stand still with what they have telecare-wise is going to cost them. So they're looking to mainstream and digital because they are comparatively cheap, and people may already have them. They may not need to even buy them for people. So that is being considered as an avenue by some commissioners and some aspects of local authority, innovation hubs within local authorities, which is interesting, but it does open up new issues around data, security, privacy, ethics, that all need to be considered, because yes, these things are very user-friendly, they're very cheap, people may already have them, but who owns the data? What happens to that data? All these questions that it opens up, I think, are emerging and important.
Yeah, there is EU regulations in this regard. No, there is a declaration of, about European cloud that is going to be done. So I think it is work on this regard. But what we also find in the qualitative research in our case study in Catalonia and Spain was that while there was a lot of digitalization in health, and the information and the data for health was easily available and well organized, in terms of social services where care it is handled, was completely absent. Was not. Professionals, primary care, doctors, nutritionists, when they tried to grasp what was the Care Law Act, no, that we have in Spain implemented or no, what services. Nothing. Also all this complexity in terms of information that you need to submit. So it is really a lack of digitalization and information in terms of care services, and in terms of the files of the care files and social service files for users. No? And this is, it is something that needs to be improved and takes time. No, it is the example of Estonia as the one who has done better because it starts from zero. And there is different initiatives in other countries and heterogeneities. But this is also something that I think it's lacking, and I think there is the EU regulation in this regard. I don't know. Yeah, of course, now Britain is a topic, I suppose.
Yeah.
Okay, to mention. Sorry, I said, and then I forgot that about the Brexit. But well, I don't know. Imagine that will be regulations in this regard or similarities. But you go faster with the vaccination, so don't worry. Something you do.
Well, we might slow down in a minute.
Yeah, that's true. Yeah, I think you mentioned, so thank you for that comment as well. I think you're right. I think the perception is that health services, regardless of what country you're working with, that are much more with their offering digital technology, digitalization. I think what would be interesting to see is what the mechanisms have been for that, right? Well, one, is that perception actual reality, right? Or actually, are there kind of instances where a lot of health services actually are lagging behind digitally as well, right? Just a few exemplars that push that perception more broadly. And then also, if it is in fact lagging behind, why is that? Is it due to the austerity cuts? Is it due to other factors that would, have impacted these social service systems, social care systems across these different countries? And actually, Maxie, I was really excited to read about kind of the new policies emerging in Germany, the Digital Care Act from 2019, and I can't remember the name of it off the top of my head, but the one that's going to attend, I think it'll be published in 2022 as well, you mentioned.
Yeah.
So I'm excited to see actually social policy focusing explicitly on digital care, not kind of having digital technologies embedded with it in other kind of policy documents. So really looking forward to diving into that after this call, actually.
Yeah, I actually think what is also interesting in line with those kind of developments, that there are already lots of organizations coming up that really try to combine care and digitalization. So I think we discussed from always different viewpoints really, and no one really wanted to leave its position. And I think combining those two fields is a real improvement. And if politics does so, I think yeah, we can see that as a good sign. Still, I think it shouldn't be too optimistic when it comes to the implementation of digitalization, because it's important. I'm not a negative person that way, but to look at the outcomes and to really leave the choice of freedom here in some ways under consideration of good care, I think is really important. But to find structures that digitalization is possible, I think this is a very important step in Germany, because at many points it's not part of the system so far.
Interesting. I think one thing I'm interested to see in when I read the document is by having policy focusing especially on the digitalization of care, does the technology become more of the focal point there rather than how it helps to deliver or enhance care, as opposed to legislation and policy which may focus on care explicitly, in which case then focuses on how technology may deliver that, right? So by having the language change, is it changing how we focus and discuss these kind of, discursively, the intentions and goals of these new policy developments? You don't have to respond to that. It's just something I'm interested in investigating as well. Right, questions for each other. I'm conscious of the time.
Sorry?
Did anyone else have any
Could you
outstanding
please-
questions?
I think Blanca asked for repeating your comment, Matthew.
Thank you.
Which comment? The request for questions or the request for, or what I said before about the public policy side of things?
No, you just cut out and you asked if there were any questions.
This
Right,
Any
sorry.
final
Yes,
questions
just-
for each other?
Yeah, so sorry. Just are there any other questions for Blanca or Maxie?
And actually, Blanca, I was really interested. You talked about a really involving approach. If you look at those different countries, what differences did you observe with regards to involving policies and openness, really, to do that?
with the fourth countries we were in the study, how the digitalization approach well,
patient involvement really, and carers involvement, and because this is something I think Germany is on its way to learn right now, how participation really works. So I'm curious about what you observed in other countries, or how is the attitude in Spain?
well, I don't think there would be so much differences in all Europe. No, I mean, we found that professionals, I think they are very good professionals and try to do the best of they have. For instance, what I have looked more, maybe I can say in terms of deinstitutionalization that has been done in Europe, in northern countries, and also in Central Europe, in Germany, and more fostering aging in place. I had not this discourse, and this has emerged as a need, clear need in with the crisis of COVID and with all the adults. And in this regard, I think it's professionals, care workers have very bad working conditions. Still, they have to work. Some of them, they just leave the job because they cannot cope with the increasing care burden, and also because on unethical reasons, no, because they cannot treat people with the enough time and quality, no, that they want. And in this regard, um, I think some countries go better, but there is a in this. I think this is something to be improved. I wouldn't see that there is an example to follow, if or a model to follow. I think there are a lot of shortcomings and things to improving, and the person-centered care can be maybe more developed in Nordic countries. But there are cultural differences. I was stuck for cultural difference I see in this project or in other networkings. No, like for instance, for us, I mean, COVID-19 has been not to meet, not to go out, not to have celebrations with the grandparents, etc. Although the society, we don't have to follow stereotypes. I mean, things are changing. Yeah? Individualism. But in Nordic countries, for them, they see that COVID-19 has not changed much the way all the adults feel, because they feel isolated sometimes, or some of them. No? So I wouldn't say, from what I see, the research and others, that there is a model to follow. I see shortcomings in other places. Maybe in terms of institutions, the more work institutions about institutionally, about short groups, about person-centered care in some northern countries than in others. But I wouldn't say it is also functioning. Also, there are criticisms about privatization or marketization of a lot of these processes. So I think it is a lot to do, and I think it needs to be a community engagement in this sense, because I mean the people, the demographic change is here, and is going to be here the years to come, and technology can help, but how? So I think it needs to be, so I think this, I don't know, I mean, only with welfare states it's not going to be enough. And also, maybe sometimes when I teach to my students about integrated personal-centered care, they say many times that, well, there is not resources, or there is no resources, or things like that. But I think sometimes certain imagination or creativity, you can do things. If you have the idea of this person-centered care, you can imagine, or you can make some progresses. I don't know if you know what I mean. No, for instance, I don't know, little things that you can do in an institution to have a better person-centered care without many resources.
Great, thank you, Blanca, for that response. any other questions? If not,
I
then we can
context,
end.
it's also important. So only one thing before the context, it's also important and make a difference. So I mean, to go too deep in your context, I think more than looking for models, although comparative, it's important. I think it's also something that we imply in the project. Sorry, Matthew. Okay.
Oh no, not at all. Actually, I think context is a very important thing to discuss because I think we often take it for granted, and actually realizing that context is not static, it's dynamic, right? People may define it in different ways. That's one of the challenges when you see a lot of realistic evaluations coming out of new technologies with the whole CMO model, right? So the context, mechanism, and outcome, realizing that the different stakeholders involved in that, whether they're older people, people with disabilities, family carers, care workers, care managers, may all define that context and therefore the resulting mechanisms and outcomes very differently. So realizing that contextualization is an ongoing process, and how we define that is very critical for how we look at how we evaluate technologies, which of course is the theme for this session today. So I think it's a really good point to raise at the end there, Blanca, so thank you. And now, without further ado, I will end the session. So I want to thank Kate, Nicole, Blanca, and Maxie for your contributions today. It's been fantastic. And I want to thank you, the audience who's hopefully viewing this online right now. This is the fourth session of this, so if you've missed any of the other sessions, we have sessions about aging in place, role of technology there, looking at how technology, advice, and information is available to support carers, and also another session about digitizing social policy. So please look at those online on the Circle website as well. In the meantime, we hope to see you soon. Bye-bye.